in the main chat box. Just a few seconds and then we'll start. For those who are joining now, we are starting in a few seconds. Okay, I think we can start now. Good morning and good afternoon, everyone. I'm excited for today's workshop, one of a series of workshops on HIV prevention needs estimates that we've been running in different regions. Just some housekeeping rules as we start this meeting. My name is Lisa Zembe and I'm part of the Global HIV Prevention Coalition Secretariat at UNAIDS here in Geneva. We are going to share the slides from this workshop together with the recording. Also, I would like to encourage us to engage using the chat box as well as the question and answer functions of this meeting for us to be able to track your questions and the panelists being able to respond to them as the workshop happens. Let's separate our general chats from our specific questions. If we get a specific question based on what is being presented or being discussed, feel free to use the Q&A function. Then any other comments or general chat that we want to have, including any sharing of resources, could be links related to what we are discussing. Let's use the general chat function for that. So as I highlighted earlier on, this is one of a series of workshops on HIV prevention needs estimates whose objectives are displayed on this slide here. First of all, they are meant to explain some strategic directions for HIV prevention in the context of the
Doctora me dice que me una reunión,
20,
la reunión es en inglés.
30 targets and a rationale for those needs estimates. Then we're going, other objective is to familiarize ourselves with the new spectrum needs estimation method or the suite of tools that are in Spectrum for doing this exercise. Also to share some basic information on more detailed needs estimate tools, focusing on PrEP-IT for PrEP needs estimate, also CNET for condom need estimates. We are also going to hear also about the Quant2 that the LAC region has been using for estimating PrEP need. Then the fourth objective is to be able to discuss implications. Yes?
Before you go on, there's a problem with the translation, so I don't want you to keep going until...
Okay.
So do you see the chat? Maybe check the chat before you keep going. Thanks. It's just a...
Okay, so IT, I thought IT had fixed this issue of not seeing the interpretation globe. IT, are you there? IT colleagues, if you may help fixing the interpretation.
Hi, Licious.
Hello.
There's a challenge on your end?
Yeah, we are hearing participants are saying they're having an issue with the interpretation.
It looks like it's just popped up, at least on my computer.
Yeah, I saw it now. So hopefully, colleagues, you can access interpretations. Yeah. Can you give a thumbs up if you can access it so that we can continue?
Hi, everyone. I cannot access the interpretation. It doesn't appear the option for me. I don't know for others.
Yes,
Yeah.
I cannot see it either.
Yeah, I can't see it as well. IT, if you could attend to this.
Sorry, Licious, the caption or the interpretation?
Isn't it when you want to hear in another language, there's a globe-like icon that you have to click and then you select your preferred language. We don't see that globe here.
But we do not have interpreter.
Ah. Okay, we should have Spanish interpretation.
I see it now. I see the interpretation and the globe. Just making sure others see that.
I can also see that.
Okay, I think you're good to go now, Lysias, and just everyone look for the globe at the bottom. Or if you don't see the globe, look for the 3 dots.
Although the interpretation is not working, I don't know if there is an interpreter in the Spanish channel, but it doesn't. You cannot see it listening in Spanish. It's only English so far.
Okay, let's just give it 2 minutes to check that, and then we can continue. Or whilst we fix the interpretations, could we make use of the captions? So you can turn on the Spanish captions, and then we can start whilst we look into the interpretation. Okay, so I was just going through the objectives of this workshop. And for those who joined later, I saw a number of people joined later. I'll just go through them again quickly. One is to explain some strategic directions for prevention in the context of 2030 targets and the rationale for these HIV prevention needs estimates. Also to familiarize ourselves with the new spectrum needs estimation tools, and to share some basic information on more detailed needs estimation tools such as PREPIT, CNET, as well as to also hear from the region on the Quant 2 for estimating PrEP need as relevant for this region. We will not go through the SHIP 2 as it's not relevant for the LAC region. Then we'll also discuss some implications for target setting and the use of these estimates, either for national plans, for Global Fund, GC8 preparations, as well as any other purposes that colleagues may want to discuss during this workshop. Also, as I highlighted earlier on, we have run a number of these workshops for different regions and epidemic types. This is the 4th one of those workshops that we are doing today. I put a question mark on the last one, as it's unlikely that we'll do that last workshop for high-income countries. This slide is showing a detailed agenda. For today, we're going to have opening remarks from Mary Mahey, then Clemens will come in to provide us with some 2030 prevention access framework overview, looking at the targets and rationale for the needs estimates. And then we have a detailed overview of and the functionality and assumptions of the spectrum prevention needs estimates tools as well as targets from Avene Health. We'll then go into detail into specific tools after that. First, PREPIT for estimating PrEP need, as well as PrEP impact by our PAO colleagues, also on PrEP need estimate, as this tool has been used in the region over a few years. Then would like to go through some exercise that will then be integrated with 10 minutes of a health break. So during that exercise, feel free to take coffee and stretch. After that, we'll come back and have a look at the condom needs estimates, where we'll look into detail into how that is done in Spectrum, as well as CNET condom estimation 2. We'll then look into the fourth part of this suite of prevention needs estimates, suite of tools in Spectrum, looking at the key population size estimates from our colleagues here at the Data for Impact. And then after that, we can have a final discussion, discuss how this could be linked to Global Fund GC8 application processes and any other country support needs that colleagues may have in the region. Without further ado, I would like to hand over to Mary from Data for Impact for our opening remarks, in the absence of Dr. Ford. I think he's not around. Over.
Thanks, Lysias, and sorry for that. Just getting my slides up there. So thanks everyone for joining. My point here is just to make a few key points on what is the linkage between what we're doing today in this discussion, as well as the bigger global AIDS strategy and global AIDS targets and the global AIDS monitoring as well. And so I'll just take you through 2 slides here just to make sure this is all very clear. Since apologies for the very busy slide here, but what happens every 5 years is we set out global AIDS targets that we're trying to reach, in this case by 2030. Within that, we say what's kind of the most critical things for governments, for communities, for districts to achieve in order for us to reach those goals of a 90% reduction in new infections and 90% reduction in AIDS-related deaths by 2030. So the global AIDS targets get set, and then we go back and figure out what are the strategies, what are the actions that are needed in order to achieve those targets. And so the global AIDS strategy has recently been proposed, and it will be brought to member states of the UN in June for them to adopt. We've gone ahead and started using those targets ahead of time, though, because we need to be focused on a smaller set of actions for countries to take on by 2030. So what we have on the right-hand side of this screen is that list of what we now have is 16 global level targets that we hope countries, districts, communities will achieve in the next coming 5 years. Within that, you can see prevention is the second one there. It's absolutely critical. We've got a high-level target that speaks to a situation where you can compare all the different prevention activities that one individual could have access to. And Clements will speak to this a little bit more clearly. But what we have underlying that high-level target there is specific targets on each of the different areas. So whether it's condoms, whether it's PrEP, whether it's OAMT, all of those we want to be seeing what progress looks like towards those by individual countries and by individual prevention efforts. So this is part of what we're doing within the global AIDS monitoring. Why this comes in through the estimates process and why this invitation came out very kindly from both Fode's team and my team is because we're trying to say we want to incorporate the denominators that you need for prevention in the estimates process. And so that we're going to go through a whole process here as Lysias has introduced, talking about what this looks like from the modeling perspective. How can you produce those estimates so that you then can report on them through the global AIDS monitoring? So that's the last piece there. And if for those of you, I think there's some people in this meeting that might not necessarily be focal points or epidemiologists, you might be prevention focal points from the country. You should recognize that within your country, there's also what we call a GAM focal point, and that's the person that enters data into our online tool and submits it up. And this last slide that I have is what that new online tool will look like going forward for PrEP. And this is PrEP as an example, but we have condoms as well. And what we're going to ask you for is to put in the programmatic data, a number of people who are receiving PrEP and by the different types of PrEP. But then we also, that bottom piece there on the estimated person years of prep needed for the reporting period, that's what this discussion is all about here. And so we'll come back to it in more detail, but just so you recognize the linkage between what we're talking about today, the global AIDS targets and the strategy, and the respective global AIDS monitoring, it all comes back to this online request that we make to you every year and hope that you can submit that. Thanks, Lysias, back to you.
Thanks, Mary, for that overview. Linking these two processes together to make it clear for colleagues as we proceed with the workshop. I'll hand over to my colleague Clemens to link this now to the Framework 2030, HIV Prevention Access Framework 2030, after which we'll hear from Avene Health on an overall presentation around the suite of tools in Spectrum. So over to you, Clemens. Thank you.
Thank you so much, colleagues. I'm speaking from Nairobi in Kenya, from the Global HIV Prevention Learning or Regional Prevention Learning Meeting. So I hope you can hear me well and see me. I'll be introducing briefly the Global Prevention Access Framework, which, as Mary already said, is an elaboration of the Global AIDS Strategy, specifically for primary prevention. Can you see my
yes,
slides now?
if you could put them in presenter slideshow.
Yeah.
Yeah, thanks. Yeah,
Good.
it's good.
And this framework is actually developed at the critical moment for the prevention response, where the HIV prevention response is at the tipping point, and we see that we still have an opportunity to achieve ambitious targets to reduce HIV incidence by almost 90% compared to 2010. But there's also a risk that if we reduce focus on prevention now, we will slip backwards and have rising HIV incidence again. And specifically in those contexts where we already have stagnating levels of HIV incidence, which I believe applies in several countries of the LAC region. The bold vision is that by 2030, every person should have access to an HIV prevention option that suits their need. But at the same time, we know there's the reality of a funding crisis and the need to optimally allocate resources. The new framework proposes a number of transitions from the old framework. So the new framework is represented here in the column 2030. So a transition from intervention-centered to a more integrated person-centered approach, from limited options, all requiring daily adherence, to expanding over this period into long-acting prevention options. We want to move from aspirational long-term targets to numeric annual targets. And as Mary already illustrated, the basis for such annual targets is a denominator or needs estimates, both for peoples and products of HIV prevention. We have a proposition to move from a project-based prevention approach to one national prevention program approach with sustainable, more standardized costs, from a mostly provider-initiated to a self-care model, and donor-dependent, which of course applies to varying degrees in your region, to a domestically owned and shared responsibility-based approach. The new framework has an underlying person-centered approach with those 4 dimensions: communications and behavioral, so more the demand side of prevention, access, platforms, and for all of those dimensions, a systematic approach, so systematically designing access platforms, addressing structural barriers, and then, of course, an optimal mix of prevention options for the specific population. The targets follow a cascade logic with a denominator, which is people in need of prevention in these regions, primarily, of course, key populations. 95% of the population in need actually being reached is the coverage target, And then if 95% of the people in need of prevention actually use prevention, this turns into 90% of all people in need of prevention using prevention options similar to the treatment cascade. We have, and that is, I think, an entry point into this into this needs estimation, a new approach to actually framing targets in a quantitative way. Globally, this fits into a 40+20 slogan: 40 million people living with HIV on treatment, 20 million people using PrEP options, 20 billion condoms. And then, am I too fast? And then we have people-centered targets in terms of the number of people reached with prevention options. And then, in a key population epidemic, and this is much more important here, what this framing of prevention could look like is in this slide. So you could have a country-specific PrEP target, a country-specific condom target, a country-specific target for key populations in need of prevention, and then perhaps other partners of key populations or other priority populations might include, for example, discordant couples, for prevention. And this framing could then even be applied at subnational level, so at district or province level. And for each, at this level of these very headline targets, the primary purpose of the needs estimates is actually to generate momentum around prevention. This could then be translated into more detailed annual targets, so the denominators, which you would also report against and measure progress against, so more easily annual tracking of prevention coverage and actual access. The framework outlines a systematic approach to access platforms, and in the table below here you see the different populations and different access platforms and different products, and one could actually quantitatively try to map out which platforms for which products and which populations. And of course, not all of them will be relevant in your epidemic setting, so one could further simplify this. The needs estimates can also be used for a prioritization approach. This framework proposes 5 P's of prioritization: the right places, right packages, for the right people, through the right platforms, so access platforms or access programs, and at the right price and the right cost. Maybe one last word to situate the needs estimates as part of other modeling exercises. So the real main addition of the new needs estimation in the spectrum model is to make this a routine annual process to estimate prevention need, just as we annually estimate the number of people living with HIV and the need of treatment. And then, of course, for specific purposes, if you want to go very granular on allocative efficiency or cost effectiveness, you could still use the goals model or other tools that are there. If you want to go very granular on PrEP, there's a PrEPIT tool. There's also a PAHO region-specific tool. For Latin America on PrEP. There's a condom needs estimation tool. So we look at all of those. The main new or the main innovation is this routinized annual synthesis of prevention need in spectrum. And ultimately, the goal of this kind of exercise would be that it doesn't stop at the needs estimate. One would actually set then a target based on the needs estimate, and then think about how can we segment this between free public sector provision, between social marketing, between perhaps private sector components, sold and out-of-pocket components. How could the public and the subsidized segments be co-funded between governments and potentially international partners? And then similarly for the people-centered programs, which is more the demand side or the access platforms, what should be the breakdown in the country for facility outreach or virtual new AI-based modalities? And again, how should this be funded? And ultimately, the idea is that this, if I go back, that this kind of framework would enable countries to effectively manage and be on top of prevention responses based on those needs estimates. So this is how the new framework conceptualizes it. Maybe one more word on how the differentiation of targets is proposed in the framework. We have 4 categories of HIV incidence, which you could apply to whatever your population definition is. So you could apply this, for example, to men who have sex with men with low, moderate, high, or very high incidence based on different either behavioral characteristic or subnational information that you may have, and often you may need to estimate this. And then the highest level of targets would apply to the very high component, and the package would gradually expand. So for PrEP, for example, we'll see that later, the highest target, 80% PrEP coverage, would be based on the very high incidence level. And then, of course, we have some minimum targets, for example, 20% of the population size for men who have sex with men and transgender women in terms of a PrEP target, independent of HIV incidence, because we know these populations often have strong demand and preference for this prevention option. So in short, it's really a new approach to prevention needs estimation, more systematic, more routine, with more granular and systematic analysis, annual tracking of progress that will allow for prioritization. So a key component of what we think is a new era for HIV prevention, and we hope that you will join us in making 2026 the year of a renewed prevention push. Thanks.
Thanks so much, Clemens. So the interpretation is being fixed. Colleagues, apologies for that. We heard that our interpreter challenges joining, but he is just joined now, and our IT looking into that now. So at any point, I'll send a message in the chat box to let you know that you can switch to Spanish for those who prefer hearing going through this workshop in Spanish. I'm going to hand over to and thanks to my colleague Clemens for that overview, linking this exercise to the HIV Prevention Access Framework 2013. I'll give to our Avene colleagues. Not sure if it is John presenting the overview, or it's Rob, or Avene colleagues, over to you.
I think we need the IT folks to unmute John and give him responsibility of hosting or presentation responsibility. Thanks.
Okay, can you hear me now?
Yes, we can hear you.
Great. I'm just sharing my screen. Okay, thank you, Lysias. So this presentation will be a brief introduction to the tool in Spectrum, and then subsequently we'll have more detailed discussions of each of the components. First, to reiterate what Clemens said, the purpose of this tool is to assist the country teams to estimate service delivery and even commodity requirements to achieve your targets. The approach is to implement simple versions of this tool in Spectrum so that you can do your calculations in Spectrum and save your inputs and your outputs along with your Spectrum file when you do your estimate. There are 4 components in the new tool called Prevention Needs Tool. The first is on voluntary medical male circumcision, which is only used in sub-Saharan Africa. But the other 3 tools are condoms, pre-exposure prophylaxis, and key populations. The condom tool is designed to estimate the needs for condom procurement and distribution. It's a fairly simple tool, so it's not designed to replace the condom needs estimation tool called CNET, which is an Excel-based tool that is more detailed and includes sections on supply and source of supply. But it is designed to give you a quick start to look at what the need for condoms would be in order to achieve your targets. Similarly, for PrEP, the tool that's built into the Spectrum is a simplified version that replicates the main calculations of the detailed tool called PrEP-It, but does not include all the details in PrEP-It. So it's not designed to replace PrEP-It, but rather to give you a quick start in looking at PrEP needs as a function of your targets for different populations. And finally, the key populations tool is designed to estimate the numbers of people in key populations that need services in order to reach your coverage targets. So here's an example of what one of the tools looks like. So this is for condoms. And you can see on the left, we have different populations. So these are different populations we would target for condom services. In the red box, we have the populations, the major inputs. Oops, sorry. Let me see if I can turn on a pointer here. Yeah, so we have, in the red box here, we have the major inputs, which are the sizes of each population in 2025 and in 2030. And then we have the baseline condom use. So this is condom use at last sex within these populations. So these numbers will be pre-filled for you when you enter the tool. So we have a database that will bring in these numbers, and we'll talk a little bit more about where those numbers come from. But it will be pre-populated, but you can change any of these inputs. So if you have better information about population sizes or a more recent survey indicating behaviors, you can change any of these numbers. And when you save your file, your changes will be saved along with it. Okay, then the blue area is the target. This should initially be filled up with the global targets, but again, you can change them. So if you have your own national targets, you can replace these global targets with those. For the condom tool, we have two additional inputs. One is the number of sex acts per year in each population, and the second is an estimate of wastage. So we've completed these with sort of global averages, but feel free to change them if you have more recent information for your country. And finally, the green box shows you the output. So this is the calculated number of condoms that would be required for each population group in order to achieve these targets in 2030. So you see the estimated need in 2025, and then the need each year up to 2030. So when you're using a tool like this, it's good to look at what is the estimate for 2025 and how does that match with your program data about the number of condoms actually distributed. The numbers won't be exactly the same, but they should be similar. If they're not similar, you may want to go back and revise the inputs in order to match what your program data show. So each of the tools follows this scheme. We have some inputs that are read from a database, which you can change. We have a target coverage level for 2030, which you can change. And then we have the calculated output. Now, if you're using this tool in Spectrum, once you open your Spectrum file, Spectrum knows what country you're dealing with, so it will automatically fill this with data from your country. Another tool is key populations, and here it simply lists the different key populations. It has the best estimate that we have for the size of those populations, and later today, Elena will talk about how these estimates are derived. We have information about the baseline coverage, which comes from GAM, mostly from reports that you have submitted to the GAM. We have the target coverage levels, as mentioned by Clemens, and then the calculated output, numbers of people needing the services in order to reach those targets. And then finally, the PrEP tool set up in a similar fashion. We have populations, sizes for each of the population groups. We have target coverage levels, and we have output. The PREP tool also allows you to specify method mix. So perhaps you're 100% oral PrEP right now, but that might decline to just 30% oral as new methods such as ring and long-acting come in, so that there's an additional output for PrEP, which is the number of person years of PrEP required by method and by year. So these outputs can hopefully help you understand the needs in order to reach certain coverage targets. So where do the data come from that are built into the model? Come from various sources. Key population sizes are based on UNAIDS estimates, which Elena will talk about. Most of the demographic information comes from the World Population Prospects, which are estimates made by the United Nations Population Division. We also rely on the DHS surveys for information about family planning and key behaviors, and your inputs to GAM. For current coverage, it's largely inputs that you provide to GAM or a national survey. And then the global targets. The targets are set initially to reflect the global targets. And then, as I mentioned, you're able to change those if you have national targets that are somewhat different. To access the tool, when you're in Spectrum, you simply go to the Tools menu, click on More Tools, and then click on the Prevention Needs tool. And it will come up looking like this, where each tool is in a separate tab. You simply select the appropriate tab and review the input data, make changes if necessary, and then note the outputs. So that's a brief overview of the tool, and we'll give you more detail about each tool as we go through the session. Thank you. Back to you, Lucius.
Thanks so much, John. Yes, now we've hit the link between this exercise on HIV prevention needs estimates to the overall estimates process from made from the data for impact here at UNAIDS, and then a link also of this exercise to the HIV prevention access framework, and now an overall view of the suite of tools in Spectrum from John from Avenir Health. We've got a few minutes for question and answers here before we can go into the specific details and each of the tools highlighted by John a few minutes ago. Feel free to post your question in the Q&A function, or you can raise your hand and then we can unmute you to speak. Feel free to raise your hand, use the hand function, then we can allow you to unmute and then you can ask questions. For these three presentations from Mary, from Clemens, and from John, if you've got any clarifying questions before we go to the next session. Any questions? I do not see any hands, and I do not see any question in the Q&A function. I'll give it 5 seconds. If not, we'll go into the specific tools. We want this to be as engaging as possible, and also would love each and every one of you to be able to know where to go in Spectrum and how to change things and run outputs and be able to interpret outputs from these tools. Any question? I see one hand is up. Yes, those Smallings, I'll send a request to unmute and then feel free to speak. Over to you.
Hi, good morning, everyone. So my question is to John. You would have said in terms of moving to looking at annual targets and stuff like that to steer prevention program. But I'm curious about coverage. If it is our population estimate is, for argument's sake, for MSM, for the MSM population is 25,000. When we look at what would inform coverage for that year to say that we would have made an impact based on the 1990 target? Over.
Thanks for that question. Maybe let's take one or two more if there are any questions, and then we can give to our presenters to respond. Any other question? And that's an interesting question. That one has come up, I think, in almost all the workshops we've been doing. So thanks for asking that. If no other question, over to you, John.
Yeah, thanks for that question. So this tool does not estimate impact. If you want to estimate impact, there's a different tool called the goals model, which we have been using, and I think we've been training people during the estimates workshops to use it. So that tool will translate coverage to impact. But in this prevention needs tool, we're only looking at the coverage. And the way that's been done is at the global level. We have made estimates of what coverage is required to achieve global impact. And then we're just translating those coverage targets back into this tool. So that's why you see Clemens suggested that key populations, 90% coverage should be reached in order to have significant impact. So we're only in this tool looking at the coverage and the number of people that need to be reached. But if you want to calculate the impact you would get by doing that, then we need to use one of the simulation tools.
Maybe just one addition from my side, right? For the specific example of an MSM population. So if you say 25,000, for practical reasons, one would further segment here. Typically, at least that's what we came up with in one consultation, to say we would estimate the proportion of men who have sex with men who have non-regular partners, because one would not necessarily need to reach, men every year who have one stable partner over a long period, right? And that would then be the programmatic denominator for this 90% target. And then, of course, the PrEP and condom targets would follow from that and would be a subset of that REACH target. And as this one slide suggested, REACH is not prescribed on how to achieve that, right? The coverage. It could be through clinical service or facility or outreach or a virtual platform. And that mix is then, of course, entirely country defined. But typically, the programmatic target could be based on on the number of men who have sex with men with a non-regular partner in a year.
Thanks so much, Clemens. And thanks, John, for clarifying that. It's very, very important concept to really grasp when it comes to this topic of needs estimates and target setting. I see another question from Laura Martinez. In which section of the two can we calculate estimates for large-scale screening programs? Additionally, is it possible to adjust the population number to reflect a specific target population rather than only using the national level default? I guess both questions could go to John, I think.
Sure. So this tool does not include screening programs. So if we're talking about screening for HIV or for STIs or whatever, that's not included in the tool. I'm sorry. Your second question, however, it is possible to adjust the population numbers. So we have these national defaults. You can replace them with better estimates if you have them of national level, or you can change them to a subnational. So if you want to use the tool just to apply it to your capital city, for example, you would just change those populations to be relevant for your capital city, and then the need calculations would be consistent for your capital city. Thank you.
Thanks so much, John. And I think in addition to what you are saying for the subnational aspect is in Spectrum, you won't be able to do for multiple subnational areas. When you change to subnational area, you only be able to do one subnational area at a time. I think that's one of the detail also that came up in one of the previous sessions. Okay, thank you. We can go to the next session now, which is going to look into details into the specific tools, and we're going to start with the tools for PrEP needs estimate. So I'll give back again to Avenir Health to give us a overview presentation of PrEP-IT. Then after Avenir Health, we'll give to our PAHO colleague, Hortensia, to present on PrEP Impact 2, which the region has been using for some time now. So over to you, John.
Thanks, Lucius. So I'm going to give a brief introduction to the PrEP-IT tool in the prevention needs model, and then Nicole Bellows will talk about the PrEP-IT tool. So again, the purpose here is to assist country teams to estimate the number of person years of PrEP needed to achieve their targets. And the approach is to enter a 2030 target, and then the model will calculate a scale up from 2025 to 2030. So first, why is it important to look at this topic? Well, almost 4 million people were reported to have received PrEP in 2024 in over 100 different countries. So it's a large component already. And of course, this is far from the global target. As Clemens mentioned, these global targets are flexible and responsive to need in the case of PrEP as defined by incidence. So if you can see the pointer options here, see this chart here in the upper part of the screen. This shows you how the PrEP target is set. So any population with an estimated incidence above 2% is assigned a target of 80% coverage. So this is the highest risk populations where PrEP will do the most good and be most cost effective. At lower levels of incidence, as we travel down this curve, there will still be some people that will have high risk, but there will be more people at low risk as well. So in that case, the target level is lower because you'll still want to focus on just the highest risk populations, which won't be everybody in the population. And then at the very lowest, there could be a minimum when incidence is below some level, maybe PrEP is not recommended at all. So this sliding scale is applied to each population. So sex workers, MSM, adolescent girls and young women, to calculate what the global target would be. So that's how that's done. And that's where these global targets come from that are in the tool. But I want to stress that you can change those if you have more detailed information about the distribution of risk within the target population in your country. So the global target for PrEP is nearly 20 million person years. And you can see how it's divided here among the different populations. So in most cases, the global target is much above where we are today. And this tool will help us understand what we need to do to get there. And just to say about impact, since it was asked about impact, the global target was specified in order to try to maximize the impact. So if PrEP use, if 20 million person years of PrEP were optimized by providing it to those populations with the highest incidence first, then we estimate that we could avert about 240,000 new infections annually. Expanding beyond that 20,000, additional infections could be averted, but the increase would be smaller. So that's how the global target was set and was linked to the idea of impact. Okay, so I mentioned that in the PREP tool, we have our inputs, which are the population sizes and the coverage. And feel free to modify those if you want to. In this particular example, you can see that it has coverage targets of 10% for MSM, sex workers, people who inject drugs, and transgender, but 0 targets for adolescent boys and young men and general population, older adults, because of incidents in this particular country. So that will be different in your country, but please look at those targets and feel free to modify them based on the more detailed information you'll have about the distribution of risk in these populations in your country. Sorry, this is the current use, and this is the target here shown in blue. And then you can see the output shown here in numbers of person years. As I mentioned, you can enter a changing method mix over time, and then you get your output here. I want to stress that the output here is in person years. This is a little bit different from what you provide to the GAM, which is the number of people who access PrEP at least once during the year. So these are 2 different concepts. So we have to convert between one and the other. And basically, generally, we convert by using a factor. And in this tool, we've been using a factor of 0.58, which means that for every 1 person who accesses PrEP sometime during the year, that's equivalent to about 60% of a full person year of use. So that's the difference between these 2. So this is the tool that you'll see when you start Spectrum, and allows you to get a high-level look at how your needs can be calculated. So I'm going to stop there and turn it over to Nicole to talk about the detailed tool, PrEP It.
Great. Hi, everyone. Let's see. Are we seeing my screen in the
Yes.
proper format?
Yeah. Thanks,
Great.
Nico.
Hello, everyone. My name is Nicole Bellows. I also work at Avenir Health and am going to give you an overview of the PrEP It tool. PrEP It stands for the PrEP Implementation, Planning, Monitoring, and Evaluation Tool. It was first developed in 2019 under PEPFAR USAID funds through a number of projects and has had some continued development since. It's a decision-making and analysis tool with different interrelated modules. So like the tool that John just described, it does target setting, but it also allows you to go into more depth to do more cost forecasting. It does allow for estimating impact and is useful for commodities forecasting as well. So I'm going to touch on the highlights of the tool. This is what the landing page looks like. You use the start button on the left under PrEP It. There's also a function to aggregate multiple subnational estimates of using the tool. On the right, that's used less often, but available. The tool right now is in English and French, and is pretty easy to access and get started with a lot of built-in default features for users. So a lot of countries have used PrEP It, primarily for target setting. There's also been some use for commodities forecasting and different grant applications. More recently, it's been used to help plan for their lenacapavir rollout. In terms of the population estimates, it focuses on estimating the number of potential PrEP clients as a starting point. And this is calculated by looking at the total priority population size. If there are certain geographic regions that targets are focused on, looking at percent in that region, factoring in HIV prevalence to isolate the HIV negative, and then looking at the percent indicated for PrEP, meaning those who are in need of PrEP based on their likelihood of exposure to HIV. Right now, there are 4 methods built into the tool. By default, it has pill, ring, cab, and lenacapavir, but you can add other methods or you can remove the ones that are not relevant for your particular country. If you add a method, like a new method coming out, you need to put in some assumptions around cost, effectiveness, and implementation timeframe. And like the prior tool that was described in Spectrum, there are all these defaults built into the tool, but they can be changed by the user. So if you have a different implementation timeframe, you can use these menus to adjust different costs, etc. One unique feature of Prep-It is that it tracks clients over time based on specified continuation curves, where what percent of people are still on PrEP after initiation by month. There are defaults built into the tool based on implementation research, but if you have information for your country, you can create your own curves as well. One feature that is interesting and used quite a bit is looking at the cost and cost effectiveness. There are a lot of default data built in around costs, and we look at costs, the monthly costs of the PrEP product and adherence support. And then we also track the per visit costs that have things like your personnel, labs, recurrent, and capital. And then you can also add in programmatic costs that are above site, like demand creation, management, and training. So there are default values built into the tool that are based on an analysis of PrEP costs and then adjusted by country wages and salaries. But also these can change if you've got specific cost data. And then when you combine the costs with the targets, then you can see what it would cost to achieve those targets, as well as look at the cost per infection averted by both PrEP method and population. And all these calculations take into account how long people stay on PrEP, what percent are reinitiating, what the visit schedule is in your country, and how you're planning on scaling up over time. In terms of impact, it calculates the number of HIV infections averted based on impact factors, which is the number of HIV infections averted per person year on PrEP. So using that same concept that was discussed previously. These are estimated in the goals model. And the impact factors are specific to the country, the method, and the population. As I mentioned, you can use then this impact to look at the cost effectiveness of achieving the targets by linking to the cost module. When setting targets, there are 3 options. There's setting by coverage, basically who will be actively taking PrEP at the end of the target setting period. So this is a little different than when people set targets based on the percent of the population who've ever initiated PrEP. That's calculated in the tool, but when we're setting by coverage, we want to factor in the people are not continually taking PrEP. Some people are just stopping PrEP or pausing, and so it factors in that. And so coverage is really about what percent of the priority population are taking PrEP at that point in time. You can also then use coverage but add in constraints. So maybe you want to achieve the 80% for a particular population, but you know that you're constrained based on your total costs or the amount of PrEP quantity of the product that you have available. So you can add in those constraints and then see what targets are feasible. Additionally, if you've estimated your targets in another mechanism, but you want to link to the other modules, you can enter in your targets in terms of the initiations, and it will then look at the costs, the impact, and help you with supply community commodities forecasting. And as with the other tool, you can specify your method mix when setting targets, especially if you're making a change and shifting to different methods over time, it allows for that. So I sort of hinted there's a lot of different outputs that you can look at in terms of, the PrEP new, PrEP CT, et cetera. It can tell you how many initiations and reinitiations to expect. Look at infections averted, the cost per infections averted. They'll tell you what level of coverage is achieved, and then also, the percent of potential users who are expected to initiate. There is an optional feature to disaggregate these targets to subnational areas. And then the commodities forecasting helps link you to show monthly estimates of when to expect the visits, the amount of product that will be needed each month, as well as the commodity costs. So like I mentioned, there's a lot of details in this tool. This is a tool for wanting to kind of go deeper on PrEP and really think about some of the planning aspects. So while we've touched on the highlights, there is a series of instructional presentations on PrepWatch that can be used to navigate and go through the tool and understand all those inputs. We also have the Prep It Help email if you've got questions in using the tool, and you can engage with our online community of practice to see how others are using the tool and get advice from other users. So I'm going to stop there, but happy to answer any questions.
Thanks, Nico, and thanks, John, for the overview of PrEP needs estimates as it is in the spectrum, and also using the standalone to PrEP2. One thing that is different for this workshop for this region is the next presentation on the PrEP Impact 2, which our colleague Hortensia from PAHO is going to provide us an overview about, and then we'll go into a Q&A session for both tools combining for PrEP needs estimation. So over to you, Hortensia.
Thank you very much, Lysias, and thank you very much from the team. I am here with Bernardo Nuche, our technical officer of HIV, and with engineer Ever Davila, is a consultant from PAHO. We together we will prepare for the question from the audience. I'm trying to share my PowerPoint presentation. Okay. Okay. I'm not sharing. Sorry, screen 3. Can you confirm that is your seeing?
Yes, can you put in slideshow mode? I think you need to click that small icon at the bottom right.
Yeah, I have three.
Yes, yeah. If you click again.
I have 3 screens, that's the problem. Let me try again. Okay.
Yeah, perfect. Yeah. Looks good.
Okay. You're seeing the PowerPoint presentation in mode presentation?
Yes, yeah, it's good now.
Okay, perfect. Okay, thank you. But I will put small this because I don't see it. Okay. Thank you very much for the opportunity to present today. I'm Hortensia Peralta. I'm the HIV and STI Prevention Advisor in PAHO. This work that we want to share with you is part of the regional effort under the Alliance for the Elimination of the HIV in the Americas, which aims to support countries in accelerating progress toward HIV elimination through a stronger prevention, expansion of the testing, the PrEP, and the treatment, and for achieve HIV elimination. We know that the situation in the Americas is not so is not improving in the reduction of the new HIV infections. In Latin America, the HIV new infection are stable, and the Caribbean we know that they have a reduction. We have the new HIV cases divided from Latin America and the Caribbean, and also the numbers from AIDS-related deaths that we are having now are approximately 32,000 from the Latin America and the Caribbean, and we need to achieve less than 5,000 deaths, AIDS-related deaths. The mortality are decreasing, but not fast enough to reach the target agreed for 2030. And if we compare actually the coverage from the PrEP for Latin America and the Caribbean, we see that the numbers are increasing, but not increasing enough for achieve the reduction of the new HIV infections. PAHO is working since the WHO released the PrEP recommendations, and in the last 10 years, we are working in the HIV prevention monitoring framework that is that constructed the cascade for prevention, but also developed a tool for support the countries for develop a PrEP target. That was the QuantPrep tool. This is available in the website. QuantPrep tool support for the countries to start the quantification and the implementation for PrEP. Actually, also was for PAHO and the countries tool for advocacy to start the policy dialogue and the guideline development. And actually, in our region, we have 29 countries that adopt the PrEP like an intervention for prevention. 2 countries that starting in 2025 with the guideline training and some few number of people on PrEP, and only 2 countries in our region that not adopted the PrEP like intervention for prevention. This setup with QuantPrep, it was very useful for the countries, but it was not enough to know the answer for the question, how many people do we need to put in PrEP to achieve the reduction of the new HIV infection? And that was a question that was started with Brazil. That is our big country and the big number of people on PrEP. And in this case, we use this evidence that on this slide, I would like to highlight an important piece of evidence that help us to define a practical indicator from planning PrEP expansion. This analysis comes from Brazil, where the national PrEP program has been implemented at a large scale since 2018. In this study, cities with more than 50,000 inhabitants were classified according to the ratio between the number of people receiving PrEP and the number of newly diagnosed HIV cases, what we call the PrEP to HIV ratio. The results show a clear pattern. Cities with higher PrEP to HIV ratios tend to have declining HIV incidence, while cities with lower ratios continue to show a stable or increasing number of new infections. In particular, when the ratio exceeded 3 people on PrEP for every new HIV diagnosis, most cities show negative growth in new cases, suggesting better epidemic control. We know that this does not establish causality, but it provides a very useful programmatic indicator and suggests that reaching a PrEP to HIV ratio above 3 to 1 may reflect a well-functioning prevention and care system. And this was the base that we used to develop the PrEP impact tool. We calculate also the coverage. That is not enough, of course. And we calculate the ratio of people on PrEP new HIV diagnosis. That was for 2023 and start in the theoretical and mathematical modeling, and the new infection equation summarize the dynamic behavior of the epidemic, because we know we have a concentrate epidemic. It model in the interaction between the already infected, that is the N, and the susceptible population through the transmission beta. The susceptible component include the interaction with the different cascade pillar and the different intervention strategies, coverage ratios, and the effectiveness such as that change in any of the pillar or prevention strategies are considered in the new infection dynamic. We have the parameters and initial values. We need all these parameters from put in the tool. I heard when John said that the number that they use, and if the country have better numbers, they can modify. That is the same here, because we are using the spectrum estimations for some of the number, or the data that was published for the country for the cascade. For example, for the susceptible population covered by oral PrEP in 2025, that is the people that is in PrEP according in the denominator, the susceptible population. We use a calculation from the studies and the CBC behavioral component studies, or if we have another data coming from the countries, we can use that. And we calculate the effectiveness of the oral PrEP in 80%, and also we include in our scenarios the lenacapavir scenarios with the effectiveness calculated in 99%. And in one of the scenarios, in the lenacapavir scenarios, combined with oral PrEP, we put the effectiveness of oral PrEP in 90%, because we calculate these people, they have the decision to continue in oral PrEP, we have better adherence. The tool is in an Excel. Bernardo will share with you the Excel, and also will share with you a link with the explanation in English, and another link with an explanation in Spanish, because we have the explanation in English and Spanish, and if we need develop two explanation of the tool in other English, we have the capability to do it. And in this, this is in Spanish, but just for the presentation. And in this part, we have the data and the different scenarios and the different year that we model it. We model the 10 years. And you can see, I put only a screenshot for the PowerPoint presentation, but Bernardo will share the Excel. And this is all the data that we put in the basal data, and we calculate the cascade and the data, and all the cells that are in blue light color are modified for the countries. And at the end, we will have different scenarios, and you can see this is the number of people that you need put in PrEP in the different years to achieve the reduction of the new HIV infection. We calculate for scenarios, and this is a better way to see it. For example, in the blue color is the status quo scenario, is how we are increasing the number of PrEP actually, that is at 3.8 approximately. And if we put if we continue increasing the number of people on PrEP on this pace, that is the blue light color, we can see in the graph at the right, okay, here, we can see the new HIV infection and only decreased the 16% until 2035. If we use the second scenario, we name this the expanded oral PrEP. It is achieving the ratio 3:1 and then increasing 5% of the coverage annually. We need to achieve 1.9 million people on PrEP for 2035. That is 75% of the coverage. And the other side in the graph, you can see the reduction of the new HIV infection will be 63% by 2035 in this scenario. For the other hand, if we use the greatly expanded oral scenario with oral PrEP, if we put 1.8 million of people by 2030, yeah, that means we need to increase the number of people, but not only increase the number of people, if not do it fast, yeah, in a few years. We need to do it fast. In this scenario, the scenario number 3, with 1.8 million by 2031, we can reduce 73% of the new HIV infection by this year. And when we introduce the lenacapavir in this same scenario, with this same amount of the people, we can achieve 83% of the reduction of the new HIV infection. This is the scenario from lenacapavir. When we put 60% of the people decide in lenacapavir and 40% of the people remain in oral PrEP, and you can see the purple line, and for 2031 with 1.8 million people on PrEP, we can achieve the 80% of reduction of the people of the new HIV infection. We have some example. We are working since last year with more than 14 countries, and I will present only 2 examples. Mexico, that they achieved the 4% of increase of the annual PrEP, and if they use the 7% annual, they can achieve the reduction of the 60% of the new HIV infection. If they use the 10%, they can achieve 90% of the reduction of the new HIV infection. And this is the example of Brazil scenario, because they already achieved the ratio. They have more than 3:1. For them, for that reason, they only have 2 scenarios. The status quo, that is, they are increasing the number of the people in PrEP. If they continue with this average, they will reduce 73% of the new HIV infection by 2035. But if they have more ambitious target and increase instead the 7% or 8%, the 10%, they will achieve the 77% of the new reduction. If they include lenacapavir, they almost reach the 90% of the new HIV infection. We put this projection and with some rapid assessment for moving also the cascade, the 99, 99, 99, and we put this from the HIV elimination projection for Latin America and the Caribbean, and we use this like a tool for advocacy from the Alliance from the HIV Elimination in the Americas, trying to prove to the country if they use more ambitious target for PrEP, they can reach the target, and we can really eliminate the HIV in the Americas. Thank you very much. And we are here for all the questions that you have.
Thanks so much, Hortensia, for that overview of the tool. I know it's quite a comprehensive tool to pick it up in few minutes, especially considering that it's the first time a number of colleagues on call are hearing about the tool, especially those not in the region. Colleagues, let's save a few minutes for question and answers before we can start our exercise. As I highlighted at the beginning, we want this to be as practical as possible. It would be great at the end of this workshop to be able to know where to go in Spectrum, where to find this suite of tools for needs estimates for these different prevention needs. Yeah, we'll go to the exercise in a few minutes. I'm just opening this up for any questions you have, either the presentation by John on PrEP needs estimate in Spectrum, PrEP needs estimate using the standalone PrEP 2, and also the PrEP impact 2 that our power colleague Hortensia just presented. Show by indication of raising your hand, and then we'll allow you to unmute to speak, or you can type your question in the Q&A function of this meeting, and then we'll be following that function to respond to your questions. You may raise your hand, and then we'll allow you to unmute to speak. I'll give it a few seconds. I don't see any question in the Q&A function, so if you prefer to raise your hand, please show by indication of raising your hand, and then you can speak and ask your question. Otherwise, we can go straight into the exercise. So the exercise is to try to be very practical on the use of the Spectrum suite of tools. I'll hand over to John again to just walk us through the exercise. We send a reminder email where we shared the Excel versions of the tools, I think, to help in doing this exercise for those who don't have Spectrum already installed. But for those who managed to do it before the workshop, you may also follow as John show us where to find what. So over to you, John, for this PrEP needs estimate exercise using the Spectrum tool.
Okay, thanks, Lucia. So you have several options here. If you're using Spectrum, and this is the Spectrum desktop version, then it's very simple. You simply go to Tools, More Tools, and Prevention Needs. This is after you already opened your Spectrum file. So here I've opened a file from Honduras. So the tool will come up already filled in with information for Honduras. If I go to the PrEP tab, you'll see the information here. You can change. Suppose you have a different estimate of men who have sex with men. Instead of 106,000, maybe it's 150,000. So I'll type in an estimate both for 2025 and 2030. Review the target. So right now this says 9%. This is based on the estimated incidence in that group. But you may have more detailed information about the distribution of risk, and you may know that the target is larger than that. So maybe your target is 15%. You can type that in. And then as you make those changes, the number of person years of PrEP needed will show up here. So you can see the result from those changes. For method mix, you can see here our default is we're assuming that oral PrEP will gradually decline. That here. Sorry, got a little too far. And that long-acting PrEP will gradually increase up to about 60% of all use by 2030. And once you've entered those assumptions, then you can see the output here. So it's suggesting that by 2030, we'll have a need for 24,000 person years of PrEP, of which 17,000 would be for long-acting and 7,000 would be for oral. So that's the way you use the tool in Spectrum. This is the desktop version. You can use the tool in the online version of Spectrum. It works exactly the same way. And then the other option is to use the Excel tool. And I'll paste a new version of the Excel tool in the chat for those who want to use it. Let me see if I can find it here. Yep. So it looks the same. Sorry, this is key populations. Where's the PrEP tool? There it is. So it looks the same in the Excel tool. This Excel tool is just really for this exercise. We don't expect to use it going forward to maintain it because we prefer that you do it in Spectrum to save your results. But for today's exercise, if you don't have Spectrum installed, you can use the Excel tool. It looks the same way, and we have both versions in English, and then there's a tab that has the tool in Spanish as well. So same thing, change any of your inputs and select your country first from the drop down here, and then look at the inputs, make any changes, and look at your results. So let's give you a chance to give it a try, and please post any questions that you have in the Q&A. Thank you.
Thanks, John, and feel free to follow those steps that John highlighted, colleagues. We have about 20 minutes to practice on this, and then we'll reflect after that through some Menti. If you missed any of the steps or you get stuck, feel free to raise your hand and we can ask John to repeat those again, or you can paste in the chat box to say you're stuck, you need some help at whichever stage, and then we can attend to that to help you out. It would be great at the end of this to be able to do this, be able to interpret the outputs for your country. At the end, this could make a great contribution for those countries that will be applying for the GC8 processes, to be able to show or demonstrate in your proposals, your prevention section, how you came up with your prevention needs and how you costed them, how you quantified them, and which methods you used. Yeah.
So I've just copied a version of this Excel-based tool into the chat for any of you who don't have Spectrum.
If you're stuck to follow those steps, feel free to ask. You can raise your hand. We'll be monitoring the screen for any hands up. Or you can just paste in the chat function there that you have a question, and then we can attend to your question. And at the end of this exercise, would like to reflect as well for the region, considering that now there are these different tools. I think a few minutes to reflect how best the region feels is the way ahead, either in using these tools, either in combination, especially for preparation of your proposals. It would be great if you can spend a few minutes at the end of the exercise to reflect on that as well. But for now, would like to make sure everyone is familiar with these tools and how to use them and how to interpret the outputs. Just we can have 5 or so more minutes. If you are stuck, please indicate by raising of your hand or paste in the chat function, and then we can address your question. Okay, I see a question asking about presentations. We try our best to make these presentations as ready as soon as possible. We'll send the recordings and slides before the end of this week. We will share a link on the Global HIV Prevention Coalition website or resource hub that will contain the recording and the slides. And we'll do that before the end of this week. Okay, 3 more minutes. We'll give it 3 more minutes, and then we can reflect on the exercise. One more minute, just 1 minute, and then we can reflect on the exercise. As highlighted earlier on, it would be great at the end of this if you can know where to go in Spectrum, also how to navigate the standalone tools, the PrepIt, and the Prep Impact tool, to be familiar with these tools, especially how needs estimates are done in Spectrum. If you are familiar with that process, that would be great at the end of this exercise. Be able to know the default values for your country, be able to know which values are editable, and be able to read the outputs and interpret them. Okay, so we are going to reflect. I'm going to be setting up a Menti to go through a Menti, but whilst I do that, I want us to give us maybe a few minutes for any questions. If you've got any questions on this exercise, you may raise your hand or you can paste in the chat function and we can answer your questions. I'm just giving a few minutes for us to do that while I set up the Menti to reflect on this. Okay, so I see a question which is saying the Excel tool shared only shows for PrEP-IT, not condoms. So yes, I see John has already responded to that. Also, the link that I shared in the email, the invite email or the reminder email, it shows links to all these Excel versions of the tools. PrEP-IT for condoms, for VMMC for those where it's relevant. And more than happy to reshare if you missed that email. Or you can navigate the different tabs also. There they are. They've been posted in the chat. The other tools, key populations, condoms. They've been pasted by Avenue Health, by John in the chat. We will reshare them as well when we share an email. One point to note is those tools are not a replacement of Spectrum going forward. Avenue Health colleagues, they just prepare those Excel tools to make it easy for us to follow through the examples. But they will not be replacing Spectrum. We still need to have Spectrum going forward. They were just prepared for this exercise. Yes, so you can either use your phone to scan this QR code, or you can, on your laptop, enter www.menti.com and enter that code 63598173. We just want to spend a few minutes reflecting on this exercise. You can scan the QR code with your phone, or you can enter www.menti.com and enter that code 63598173. Whilst we join, I see only 19 have joined the Menti. Let's join and let's give our reflections. Let's reflect on this exercise to be useful for us to be able to see how useful it is and also how best to further help. www.menti.com and the code is 63598173. Or with your phone, you can just scan that QR code shown on the screen. I do not see any questions in the Q&A function. I don't see any further questions in the chat function. We have got 24 people now on the Menti. I'll give 5 more seconds for those who want to join Menti, and then we can spend just a few minutes to go through the Menti. Okay. Yes, so the first question is, what surprised you about the inputs into spectrum prevention needs estimates? As John was presenting the different parts of the tools, what surprised you about the inputs? What surprised you about the inputs into spectrum prevention needs estimates too? Waiting for your responses. Okay, somebody says the data, the input data. No surprises. Okay, let's keep them coming. Let's keep them coming. It's good to see how you are viewing this. The clarity, no surprises, no surprises. Okay. What surprised you about the inputs into spectrum prevention needs estimates? Any surprises? I'll give maybe 5 more seconds and then we can go to the next question, next reflection question. It's interesting to see. Most are saying the data, the input data. And as John highlighted, that there are parts of this data that you can edit, the input data. If you've got more updated data for your country, or you've got updated information for your country, feel free to edit those editable parts of the input data. You might have seen maybe some figures that are not updated for your country. And if that surprised you, just note that those input data you can edit. You can edit and enter the correct data or the most updated data. Okay, this is great to see. No surprises. Data mostly is what is surprising most. Coverage of the data, the use of person years. Some years it's pretty straightforward. The different population aggregations, we can see that it's different things for different people based on how we are understanding this. So more practice will help us, I think, to master these tools or the different components of these tools. The next question is, what surprised you about the results? What surprised you about the results of these prevention needs estimates tools from Spectrum? Let's keep them coming. What was surprising about the results as we're walking through those files, or as John was walking through the files? What was surprising about the results? Yes, as expected. That's good to know. Nothing surprising. Results very useful. The per year interpretation of the results useful. It's possible, feasible. Nothing. Okay. Okay, that's good. The level of PrEP uptake, results expected. Okay, this is good. This is good to see. I'll give 3 more minutes. I see there are 32 people on Menti and 8 have responded. So 3 more seconds to respond to that, and then I go to the next question. Okay, looks like everyone is pretty much familiar with this part of the workshop, right? Nothing surprising. Mostly is the response there, meaning that people kind of grasp the use of these tools, where to find them, how to navigate them, and how to interpret the result. This is great to know. So we are going to go now to the next part of this, which is the last section of presenting the tools. I'm going to hand over to John Stover again to to share on the condom needs estimates, the approach in Spectrum, and then our colleague Clemens will present on the condom needs estimate 2, the CNET 2. And then my colleague Eileen will present on the key population size estimates as well, which is also in the Spectrum suite of these tools. So over to you, John.
Thank you, Lysias. Just a moment while we wait for it to come up. There it comes. Okay, so we already talked a little bit about the condom needs tool, but like the PrEP tool, the purpose is to help country teams estimate condom needs to achieve your targets. Why is this important? Well, again, from submissions by countries from their program data, looks like over 700 million condoms were distributed in countries in this region in 2024. You can see the distribution here by country. It's also useful to think about what have been the past trends in condom use. So we do have some data from multiple surveys over years showing us the trends. Surveys are a bit old now. We don't have many recent surveys. But we can see that historically, up until 2017 or so, there was a trend of perhaps a slow but gradual increase in reported condom use at last high-risk sex. Maybe that's leveled off a little bit now, but these values are well below the target values. So as you look at the tool and consider the targets, the global targets and the targets you want to use, it's important to think about how much scope there is to actually increase condom use considerably above the current levels and what would be required to do that. In the global strategy, there are several targets that refer to condoms. As Clemens mentioned, 90% of people in need of prevention services should use different prevention options, of which condoms is one. 95% of the estimated needs should be available to distribute, and 80% of people should use a condom at last sex with a non-regular partner. So those are the global targets that are there, and they'll be built into the tool. You can modify them as if you have different national targets. If all the targets were met, then we would see about 5.5 billion condoms distributed in the LAC region, so a big increase from what we're at currently. So the tool is, just to reiterate what I showed you earlier, the tool has the input section, the target section, outputs in green, showing you the number of condoms used. And if you're going to try out the tool, certainly take a look at what we have here for the estimated need in 2025 to compare it with your program data and make sure that they're somewhat similar, and if not, adjust some of the inputs. So if you've already tried out the PrEP tool, the condom tool will be very similar for you. Just a few key considerations. A lot of the condom use is among key populations, so please take a careful look at the estimated size of the sex worker and the MSM population in particular to make sure it's the best estimate available for your country. Think about the feasibility of reaching the targets, whether it's the global targets, which are quite ambitious, or your national targets. And then finally, we know from lots of different analyses that condom programs are highly cost effective. And in fact, in most situations are actually cost saving, which means that the cost to implement the program is less than the savings that would be derived from reducing new infections and having fewer people to treat in the future. So any deterioration in condom availability will have serious consequences, both on trends and cost effectiveness of the program. So these condom programs are highly cost effective, and really need to be prioritized to make sure that distribution doesn't fall short. I'll stop there and turn it over to Clemens to talk about the CNET tool. Clemens, thank you.
Thank you so much, John. I will speak very briefly to the CNET tool, which is an independent tool available through MS Excel and available on the Global Prevention Coalition web page for download as well. And we can also put a link to the chat. So I'm bringing up the presentation, and I hope you can see it by now in putting it in presentation mode. So here you have the link that I hope colleagues can put in the chat for you to download as well. The CNET tool is in a way more comprehensive tool, as John mentioned, as it also includes supply side considerations. But maybe one step back, why condom programming is important, even in a setting where, as I imagine in many countries in Latin America, there's a fairly large share of private sector market for condoms. Programs can often correct for, potential failures of the market. And what we see if we look at our data is that there are actually quite substantial differences in condom use in the Latin American region. We see here sex workers and men who have sex with men. For sex workers, a global benchmark is 95% use, which has been achieved in several countries. Here you also see in several countries in the LAC region. For MSM, in the absence of scaled PrEP, perhaps 75% or 80%, as we have in the target, could be a benchmark. And you see there's also several countries below that benchmarks, and some other countries have actually achieved it. So that shows that actually having programmatic effort around condoms can help achieving levels of condom use that have been achieved in other countries. Of course, not only for HIV, but also STI prevention considerations. And what we see in countries where we have available data is that there is still some inequity in condom use between populations of different income levels. So the CNET 6.2, which is the latest version, is a prevention needs estimation tool, but also a data analysis tool, really programming tool, looking at different populations and trying to understand the needs of those different subpopulations that you saw listed in John's presentation already. So the populations are the same, but the tool allows for additional considerations in programming. It has a costing component and really in its full application involves a catalytic process that through discussing all the data inputs builds ownership on the process. So the overall setup in terms of populations and inputs is actually the same that John explained. So the needs estimation using CNET or Spectrum would basically be the same, and as mentioned, they extend beyond HIV, including needs for contraceptive purposes as well, based on specific inputs for couples using condoms for contraceptions and also the gap there. So it has actually a number of complementary functionalities there. It goes more deeply into defining the commodity mix, male and female condom mix, also goes into specialty condoms and lubricant consideration. And it has this additional design element that allows to think about the total market approach. So different sectors, public free distribution, social marketing, private sector for different populations, and the cost component as well. So this slide gives you a comparison of the features and basically, without going into the detail, the CNET goes beyond this needs estimation into a more detailed stakeholder process, and you can weigh the pros and cons based on this. This is just describing some of the input sheets. So you have a demographic component using the same UN population projections data as the underlying population, and then specific population sizes for subpopulations in part based on population-based survey data. The CNET is not available for as many countries, so you would not have it pre-populated for many countries in the region, which is a disadvantage. So actually the spectrum, which is pre-populated for almost all countries, has a strong advantage here. And ultimately, beyond the Global Fund GC8 guidance, where I'm not sure how many countries actually procure condoms through the Global Fund still, it's important to consider in settings where you have fairly strong reliance on private sector market, what is really the complementary focus. And what both the spectrum needs estimate and the CNET tool can provide you in this context is actually a full picture of the condom need, and thereby, based on that full picture of the condom need for different populations, for different purposes, different types of sexual relationship, is to say, where should we actually, in this country context, focus our limited public subsidy for condoms? And of course, there are programs like Brazil, even an upper middle income country, still has a strong public sector condom investment that could be, for example, where you still have that refined based on a tool like the CNET or the condom needs estimation in Spectrum. Here you have a link to the user guide, which provides way more detail, and here's some final recommendations in terms of people-centered condom programming remaining a critical element of HIV, but also STI prevention. And yeah, both tools can be useful for informing funding processes depending on how much detail you want at the analytical level. But you can of course also use what is in the Spectrum tool, which is pre-populated, and then make some considerations, for example, on total market approaches, on segmentations of populations outside the tool. So thanks. I'll end with this here. We'll also share these slides for you. And with that, I think back to look at perhaps the spreadsheet and some examples. So Lysias,
Thanks.
John, I'm
Thanks.
done
Oh,
here.
thanks.
So maybe I don't know if we want to bring up.
So I was going to ask Eileen to present on the key populations piece, and then we'll give it back to the colleagues to reflect. So Eileen, are you there online, Eileen?
Yes. Hi.
Over to you.
Yeah, thank you very much. Yes, I'm here. Good afternoon or good morning, everyone. I have a very brief presentation just to explain where this new tool got the key population size estimates from. And you see, okay. Here it is. Please, can you confirm, can you see the slides all right?
Yeah, yes, looks perfect.
Good, great, yeah. So my name is Elena Korenramp, and I work in the estimates team in UNAIDS Global Center. And so, as most of you will know, we work producing the annual national estimates. In addition, we also do key population specific estimates of group sizes and infection estimates at the regional and global level. And those are related, as you will see, to the assumptions, the pre-populated data in this new tool. So what are the UNAIDS consensus estimates for the key populations? Essentially, we updated this recently. We do this every 2 years. They are national population size estimates. that most countries report through Global AIDS Monitoring, GAM. Additionally, however, we consider also other national size estimates if they are quality, representative of the country, and possibly peer-reviewed. So what we've considered for the current PSE estimates is also a systematic review done at Imperial College London by Ollie Stevens last year, which includes such additional published national size estimates. Some countries confirm or consolidate their size estimates in a national epidemic model, and that's even better because it forces consistency of the size estimates across the key populations and with national results and versus low-risk populations. That's mostly the case for countries in Southern Africa, Eastern Europe, and Asia, however. A few of the countries in the Latin America and Caribbean region will have such national size estimates embedded in their national spectrum estimate if it's an EPP concentrated model. And then there are countries that don't have a key population size estimate for one or all the key population. And for those, what we have done is we have calculated regional median size estimates. I'll show them in a minute. Expressed as percentage of population, which we then assume will also apply for those countries without a national data point. So these size estimates for all the countries, all the 4 key populations, were produced and used for the latest estimates of key population infections, covering the period 2010 to 2024. This was published in the World AIDS Report end of 2025, Overcoming Disruption, you see here. And it's being used by the Global Fund for Grant Cycle 8 grant allocation adjustments. Here you see the regional medians corresponding to these country estimates, and so used as filler for countries without a national population size for any people. For example, in the Caribbean, sex workers by median cover or represent 1.63% of all the adults 15 to 49. That is 1.6% of men plus women. It will be double that compared to women alone, so 3.2% in the case of sex workers in the Caribbean. And here once more, the link to the infection estimates these population sizes were used for. And you can also there see the interpretation of the infection estimates, just for background. That was it. Thank you.
Thanks, Eileen. So yes, colleagues, we are close now to the end of this. We see I've got some minutes to reflect and also some minutes to go through a Q&A session. We started off at the beginning. We started going through the link between the overall irregular estimates process that many of you are part of, and this part, the prevention needs estimates, and then a link to the 2030 HIV prevention access framework, the rationale behind that, and also the need for us to have these prevention needs estimates, and then an overview of all the tools, these 4 parts of the prevention needs estimate suite of tools in Spectrum by Avene Health. Then we went into specific presentations for the specific tools, looking at estimating the need for PrEP, estimating the need for condoms, and then also estimating key population sizes for the different key population groupings. And then we looked at standalone tools that can do more detailed analysis on these HIV prevention needs, the PrEP 2 and also the condom CNET 2. So now we are open for any questions, any reflections before we do another short Menti. Any questions or any reflections that you'd want to share? Feel free to post in the chat function, the Q&A chat function, or just raise your hand and then we can unmute you to speak. Any reflections on what we've covered so far? How you feel about these tools, their relevance, either for your work, for your country, or for some processes that are upcoming in your country. Any reflections? I'll give 5 more seconds. I know at times it's difficult to figure out where this hand function is on Zoom. 5 more seconds if I don't see a hand, and then we can go the next bit of the next Menti for today. The links to the CNET2 has been posted in the chat, in the general chat box there. For those who haven't seen the 2 and who would like to navigate the CNET2, the link is in the chat box. Okay, I don't see any question here. I think from the condom needs estimates as in Spectrum, John has shown us where that is found in Spectrum and walked us through where you can add default values, the different population groupings there with different risk and assumptions made, that too. And also Clemens has done the same in a very short presentation of the CNET2, which the link is in the chat box there for those who want to go further and practice. I'm going to share again my screen. Then we can do another quick Menti, after which we can just reflect on your Global Fund processes and any reflections that you might have. So again, you can go on menti.com, www.menti.com, and enter that same code again, 63598173, or scan the QR code. I see most of you didn't log out, you're still there. Let's see some thumbs up. Thumbs up if you're still active on Menti. I see 1 thumbs up there. Okay. www.menti.com, and the code is 63598173, or just scan that QR code, then it will take you to the Menti. Now that we've covered all these tools and the overall presentations about these tools, how confident are you in using Spectrum Prevention Needs Estimates tools? How confident do you think you are in using these tools? Noted. Okay, so you have to use a rating here from not at all confident to very confident. Just have to slide your scale there to indicate at what point. From the far left, not at all confident, to the far right, very confident. Like I'm not confident at all in using these tools, or I'm very confident. 8 of. Okay, I'll show the results once we have a few more responses. 9 out of 33 who are on our Menti have responded. 5 more seconds, and then I will show so that we can see how are we feeling after almost 3 hours. How confident are you? Not at all confident or very confident? From 1 to 5 on a scale of 1 to 5. 5 being very confident and 1 not at all confident. Let's see how it looks like. Okay. 3.7. Okay. Okay, that's more than half, 3.8. It's increasing. Looks like the ones who are more confident are responding now. Okay, that's great. It shows that I think we have an idea. Now we know where the tools are at. Maybe we need more time to practice for us to be able to go further towards the very confident side of the scale. We have an idea. We know what the tools are. We know where to find them. Maybe now it's more time that is needed to play around with the tools the input data, how to run those tools, how to interpret the outputs, and how that can be of relevance in the work that we do for our countries, and also how we can apply the outputs as we do Global Fund applications or any other funding proposals that you may do as a country. Okay, this is good. This is good to know. The next question is, how do you see your country using these tools or results this year? How do you see your country using these results this year in 2026? How do you see your country using these tools or results this year? Does your country do any quarterly prevention reviews, meetings? Do you do like a national target setting meetings? Are you going to do any funding proposals? How do you see your country using these tools or the results from these tools this year? Yes, we can exploit. Somebody says we can explore the use of the results. Yes, in assessment, this could be maybe to assess the status of prevention progress in the country. Okay. We'll give few more seconds. Okay, somebody says we are using PrEP impact. I think that would be a very good discussion for the region when it comes to PrEP. Is there any gap in use PrEP impact that you may find use in the other two? Or how do you plan to proceed as a region or specific countries in the region now presented with a suite of all these tools? Yeah, I see assessment exercise. The results will be useful this year. Any other reflections? Maybe I'll give, since this is a text-based question, I'll give 5 more seconds to hear. Yeah, hear more about assessment exercise, assessment. Yeah, baseline country assessment, gathering the information. Okay. Yeah, this is great to know. I guess it also takes a bit of some time as a technical working group for prevention in the country with your data people present to be able to gather all the information that is required, run the analysis, and be able to sit together with the outputs and be able to interpret them. PrEP impact have been presented and accompanied by power, so it's easier. Somebody feels it's easier to use PrEP impact there. Okay. Okay, this is a good reflection. Thanks for those who have responded. It's good to know these reflections. That's all for PrEP and condom and these tools or prevention needs estimates tools in Spectrum. Again, we can give a few more chances. Anyone who wants to reflect or say something, feel free to raise your hand. Otherwise, I'll give back to my colleague Clemens for this last bit on closing and some reflections on how we can link this to the GC8 process, and also hearing from you as well. Any last reflection? Okay, over to you, Clemens.
Thank you so much, colleagues, for participating. Okay, let me go back a moment to one slide that I showed before, and I'll put this up while I'm giving these final reflections. And ultimately, of course, these prevention needs estimates will only be relevant if they are used. And what we see in the new era of combination prevention is that we have different tools, and the need for those different tools interacts. We, for example, see in several settings, like in Australia or in some cities in high-income countries, where there's very high PrEP use. Actually, the need for condoms, for example, for men who have sex with men, has been reduced. So one additional benefit of this needs estimation work being integrated into Spectrum is this holistic perspective. What's the need for condom? What's the need for ARV-based prevention? What are the different populations, of course, in this region? Men who have sex with men, transgender women, sex workers probably being in the focus, and what are for those different populations? Where can we have synergies based on the population size information, perhaps in integrated demand generation for prevention, and what are the specific needs then for an optimal mix of prevention options between PrEP increasing, of course, in some countries, and then continued condom information as well. So bringing this together is one additional benefit, and having this routinely can perhaps help thinking about this more regularly, and then also using these baselines or these targets in the annual tracking, because an absolute number of people using PrEP or condoms might not be as useful as looking at really a differentiated denominator by population and by different prevention options. So that is what this could ultimately facilitate, and therefore I think in many countries is considered a key ingredient for shaping a new era of combination prevention. And this picture that you see here in the background, this slide, illustrates on maybe what are some of the key assumptions we need to make to effectively manage a national prevention program. And to make them effectively, we need an underlying estimation of the need. So I hope this was useful for you. All the tools will be shared, as Lysias has said. The tools are all available under the different links. And yeah, we'd be happy to have further contact. And of course, existing tools like the PAHO PrEP Impact tool remain relevant for the more detailed analysis as well. So thanks so much, colleagues. I'm looking forward to continue interactions. Thanks, everyone, and have a great rest of your day.